Hello, welcome my friends and colleagues in new video of our YouTube channel. Number 1 Doctor. Today we'll have a lecture. Hope you enjoy, get benefits. But before we start the lecture, do not forget to subscribe to our YouTube channel Number 1 Doctor. Like the video, share the video on social media. Follow us on our social accounts below the description. If you have any ideas, leave it in comments below the video.
Okay, doctor. Can we start the lecture now?
Okay, we will start soon.
Diverticulitis. This is a outpouching of usually the sigmoid colon. And so there's something called a true diverticula, which is going to go through all three layers of the mucosa. So an example of this would be like Meckel's diverticulum, which is something you're born with. But diverticulosis, which leads to diverticulitis, is a false diverticulum because we're not really going through all three layers. We're just kind of outpouching the mucosal layer. So, and then diverticulitis is just when you get inflammation of a diverticulum. So how often does this happen? Happens a lot if you are over 50. So very few people get this when they're younger than 40, and around a third of people over 50 have diverticulosis, and 50% of people over 70 have diverticulosis, and around 2/3 of people over 85 have diverticulosis. So these people are at risk for diverticulitis. Now, the main causes of diverticulosis, they are similar to the ones that you see with colon cancer. If you don't eat a lot of fiber, then you're going to have more pressure in your bowel. And where's the spot that you get the most pressure? It's right at the end in the sigmoid. And so that's where the sigmoid is going to be the biggest site for diverticulosis and diverticulitis. So you get obstruction, and so this is talking about obstruction of a diverticulum, and usually they will say that you could get a seed stuck in there, or a small piece of something gets stuck in there, and then the diverticulum will start to fill up like a balloon, and sometimes it will explode or perforate and make a big mess in your peritoneum. So that's when people start showing up at the doctor's office with crampy lower left quadrant pain. Now, it's going to look a lot like appendicitis, except it's on the right side. Except this is on the left side, appendicitis is on the right side. So a lot of times people will refer to this as left-sided appendicitis because it looks just like it. They come in with that left lower quadrant pain. Their temperature will be up, usually just mildly. If you got a real high-grade fever, then it may be more complicated. You may have had perforation, which it led to an abscess. Sometimes you get changes in bowel movements. If that's like diarrhea, then you're probably not thinking as much about diverticulosis, but Crohn's. Now, Crohn's you see in the very young, and in the old. So we're overlapping with the people that get diverticulosis. So you're going to want to differentiate between these two. And bleeding is common. Now, most people are going to show up without bleeding, but diverticulosis is still the most common cause of hematochezia. And in acute patients, then you get distension, tenderness, rebound tenderness of the abdomen. So you want to do an exam. You're going to look at the belly, see if they have any incisions from previous surgeries that might, add to your differential diagnosis. They have, might make you think about abscess or something like that if they've had recent surgery, for example. You listen. If they're not feeling bowel sound, or if you're not hearing bowel sounds, then you could be talking about a perforation. But these are people that are going to, show up in a lot of discomfort. If they don't have bowel sounds, then they're really going to be kind of sick when they come in. You can feel a palpable mass with diverticulosis in a lot of patients with diverticulosis. And then percussion, if they are distended and perforated, for example, you might have more of a tympanic abdomen. Of course, you do a rectal exam. Sometimes you can feel these things on a rectal exam. I mean, they would have to be pretty far down for you to feel. But that can, maybe help you find a mass if it's not diverticulosis. So you get some labs. You do the CBC. It can help you to know if they are anemic. If they're anemic, they might be bleeding in there. That's the same reason we get the H&H, the hemoglobin hematocrit. The white blood cell count can tell us if there is some infection. A complete metabolic panel can help us to see if they're maybe dehydrated. Urinalysis can tell us if they do have a UTI, then you might start considering the possibility of a fistula coming from the sigmoid colon to the bladder. So, and then also check an HCG, which will help you know if you want to operate, and it will also help you know if you maybe should be checking out some other things. So, colonoscopy is the big way you take a look at diverticulosis, but you're not going to go sticking things in the colon if somebody's got an acute abdomen. That raises a risk for perforation. If it's infected, then you are perforating with all that infectious material. So that's not for the acute phase, but you can do an x-ray. And if you see, free air or ileus, that can tell you if we've got a blockage from the diverticulosis. Barium enema, again, you don't want to do in the acute setting, but it can tell you if you have diverticula. And the CT is going to be a good preoperative imaging. On CT, you can see, so here's the sigmoid colon right here, and around here you get what they call fat stranding, and that's a sign of inflammation. You also get some thickening of the bowel. If there were perforation, then you can get some extraluminal air, so you get air out here in the peritoneal cavity. These things are classified on the Henoch classification. So Henoch goes from 0 to 4. I believe it's 4. You'll have to double check that. But the Hinchy 0 and 1A is a good indication that you don't need to do surgery right away. So these people you can put on bowel rest, you can give them some oral antibiotics, and you can hospitalize them if you're worried about other things. If they have immunosuppression, if they're diabetic, anything that worries you about possible infection, you can hospitalize. And then of course there's surgery for everybody else. So surgery comes in two major varieties. One is the surgery that you do at your own leisure, which means that you don't have an acute abdomen, which could lead to perforation or already has perforated. So for these people, you can go in there and you can resect the sigmoid colon, and then you can just reattach the rectum to the descending colon. And in some cases, though, if this is an emergency situation, you may not be able to do an anastomosis. So sometimes you're going to be diverting the colon, and you're going to do colostomy, and that's in cases where we're not ready, we can't get the bowel ready in time by giving the patient time to clean it out, to go without eating, and then we prep the bowel by cleaning it out. Or if there's just a lot of inflammation, then you don't go in and do an anastomosis a lot of times, because it's just not going to take. It's not going to be as likely to take, and it's a higher likelihood for infection. So, and then there's also the Hartmann's procedure, which basically means that you're going to do a colostomy, and you sew up the distal end of the resected colon, and in some cases you can go back and re-anastomose the colon, but that it doesn't happen sometimes. They're difficult to make that connection again, and so a lot of these people end up just going with a colostomy bag for the rest of their lives. So if we can avoid that, we will. The surgery it can be done laparoscopically, or a portion of it can be done laparoscopically. So you go in and you mobilize the colon, and you identify the margins of the sigmoid, which you find where the tinea coli start to splay, and that's where the proximal rectum starts. And then at the proximal end, you find where there's healthy descending colon. So you're going to start by palpating along the sigmoid wall. They describe it as being woody. I don't know what that means. I haven't felt it. So as you palpate the sigmoid, you will feel a transition as you get to the healthy descending colon, where it's not as thick, and that's where you can have the other end of your resection. You want to make sure to watch out for the ureters. You may need to mobilize the splenic flexure if you're going to do a primary anastomosis, and so otherwise you might get too much tension on the anastomosis site, and it could pull it apart and leak. And then once you've done the anastomosis, then you can fill up the colon with air through the anus, and then you fill up the peritoneal cavity with saline solution, and then you see if any bubbles come out. The anastomosis is done either with a stapler or a hand anastomosis, generally with a sigmoid resection. You can use an end-to-end stapler, so you stick one of the ends of the stapler through the anus up into the rectum, and then the other end goes around the outside, and that will staple. It'll leave a row of staples all the way around the anastomosis site, and it will also cut as it staples a slice off the end of each of the ends that are anastomosed. After the operation, you want to check for any leakage, or just monitor for leakage, which can be seen with white blood count going up, or the patient can get really sick. Bleeding, you want to monitor your hemoglobin hematocrit levels. Infection, again, watch your white blood count, and just make sure that, especially a lot of these are hospitalized patients, you're always looking for deep venous thrombosis.
Thanks for watching. Hope to see you again in next lectures and presentations. Do not forget to share and like the video. With my best wishes, Dr. Ahmad, and visit my website, drutf.net.